Sejam todos bem-vindos ao nosso grande evento de hoje. Feliz Dia da Saúde Gengival! Para quem não me conhece, meu nome é João Paulo Steffen, sou professor de periodontia da Universidade Federal do Paraná e estou muito feliz em estar fazendo essa live hoje com o professor Chapple. Então sejam todos bem-vindos. Um feliz Dia da Saúde Gengival para todo mundo. Vendo aí vários alunos, colegas, professores. Mari já está por aí também. Marco Alarcón, do Peru, PCH. Olá, Marco. A Reila. O professor Chapple falou que já estaria aqui com a gente. Professor Cassiano, boa tarde. A gente vai falar hoje sobre os passos 2 e 3 do consenso da Federação Europeia de Periodontia para periodontite estágios 1 a 3. E também a gente vai falar sobre a adaptação barra adoção desse mesmo guideline que foi feito pela Sociedade Britânica de Periodontia. So I can see that Dr. Chapple is there. So if you can send me the request. Oh yeah, there we are. See if it works. Hi, Dr. Chapple.
Hey, JP, how are you?
Good. How are you?
Very good, thank you. Busy day, but nice to see you and nice to be with you all.
Yeah, so I just read your email that you were on surgery. And
Yeah.
And we'll have some time to discuss about why were you doing surgery, right? So this is exactly the point of our conversation today. It's going to be amazing.
Yeah, I'm looking forward to it. I think there's some really, really interesting subjects to discuss because, the guidelines are, they're aimed at everybody. But for people who are specialists, then we have to think a little bit in more detail and interpret the guidelines.
That's perfect. So, let's go to the formal part of it. So just let me thank you. So, Doctor, I'm sorry, but should I pronounce it Ian or Iain? I always have this doubt,
No,
Ian.
it's Ian,
okay.
You're correct, yes.
Okay, so this is Dr. Ian Chappell. Dr. Ian Chappell is a professor at the University of Birmingham in the United Kingdom, and he was one of the co-authors of a part of the classification and a part of the so many papers. And I've read a lot about you recently because many people kept posting things about your COVID hypothesis that was recently published, and I saw many posts about it on Instagram. And I also saw about the book that you wrote with Josephine.
Yes.
On systemic diseases and periodontitis. So amazing. I mean, a lot of people know you. Maybe not the face, but they've been posting about you all the time. And it's so nice to see you here with us today. So thank you very much, Dr. Chapple, for being here with us.
Thank you for inviting me, Joe. It's an absolute pleasure.
Okay, so I think that we can start with, let's go with the basics of this guideline that we are going to discuss today. So basically, you were one of the co-authors of the European Federation of Perio consensus, and also you have BSP, British Society of Perio, adaptation or adoption of these EFP consensus. So could you please tell something, very briefly, just for everyone to be on the same page, what this consensus is for and why was it performed? So quite briefly, yeah.
Sure. So we learned from the classification system that when you produce an international piece of work, sometimes it's not so easy to adapt it to every national situation because different funding arrangements, different philosophies, different healthcare systems. So with the guidelines, with the S3 guidelines, which, as you know, is the highest level of guideline you can have, we agreed right from the beginning that the national societies would need to look at the guidelines and go through what's called an adolpment process. It's an unusual word. It means they either accept each guideline unchanged, or they modify it slightly and adapt it. Sorry, so they either adopt it unchanged or they adapt the guideline. And so the Spanish and the German and the British societies in particular got together and updated the evidence, because there was several months, maybe 9-12 months. They updated the evidence and then held their own national adolpment processes, where they decided, well, for each of those individual recommendations, do we adopt it or do we make an adaptation that will make it work in our country and our health system? And so that's what the British did, and the Spanish and the Germans. And so the British actually published it in a national journal, but it's very similar. It's 95% the same as the S3 guideline. There are some small differences.
Yeah, great. And sometimes the difference is because of the reality. We're going to talk a little bit more in details about what people have done. Also because you come closer with like stakeholders and people from your own society, then things may change. And sometimes it's also because, I mean, people didn't quite agree with a comma. There is one specific case there that it was like a comma, or the way the sentence was built. And you know what I'm talking about, right? So it was just like the way the sentence was written. But of course, it's important to endorse or even to adapt whatever is there. So I really like the work, actually. I saw CEPAS, because it's in Spanish, it's closer to us, and also the British one. I didn't see the German adaptation. I'm not sure if I could read it.
No, me neither.
Yeah, but I think it could be nice to compare as well. So, Dr. Chapple, another important thing is that this consensus defines 4 steps. And it got my eye that they call it steps and not phases. And I guess there is an idea of continuum here, right? Like the development, one step after the other. Is that so?
Yeah, we discussed actually as an organizing committee what word to use. Because the steps actually, they were generated after the meeting, after the consensus meeting. Because what we had 4 working groups which address specific areas within the treatment process. And there was a lot of overlap, for example, between what we now call step 1 and step 4. Because when you talk about oral hygiene processes, it's the same for the first visit for the patient as it is in the maintenance phase. And we were going to go with stages of treatment, but then the stages could be confused with the stages of periodontitis in the classification. So we went with the steps, and the idea of the steps is exactly as you said, it's about a journey, a patient journey. And some patients will get to step 2 and never make it to step 3 because their motivation and their engagement will not be strong enough. Whereas some patients will go maybe from step 2 straight to step 4 if they have mild or moderate disease. Whereas people with, with stage 3 disease, more severe disease, they're going to have to probably go through all of the steps to get to the end result, if you like. And it's interesting because, in the UK, it's been nice for us because we've been undergoing some major reorganizations because of COVID, really, in the entire contract that dentists work under. And it's given us an opportunity to make sure that the new classification system and also the S3 guidelines are actually already embedded in the National Health Service already, very, very quickly. So it's been a great opportunity for us to do that.
That's amazing. Yeah, so nice to see how there's all the work that you have and also the publication, it gets to the service so quickly. So this is really amazing. Congratulations on that.
Yeah, it's good.
So step 2 would actually be the treatment of diseased sites or teeth with subgingival instrumentation. And here there is this term that comes actually from the consensus, that is subgingival instrumentation. And the consensus says that they use that word because you have different terms in the literature. So sometimes people call it debridement, sometimes people call it scaling and route planning. So, I mean, I know that at least philosophically, in the philosophical aspect of this, there is a difference between those terms. You know,
Yeah.
so like route planning, you shouldn't go thorough on route planning. But I mean, in practical terms and on the effectiveness of the movement, you know. So do you think there is really a difference between these two terms, like debridement and scaling and route planning?
Yeah, definitely. There's a huge difference. It's really interesting because over the last sort of 15 to 20 years, so many different terms have been used for, I mean, we now use the term PMPR, professional mechanical plaque removal, and it's supragingival or it's subgingival. Well, subgingival PMPR really covers all of these terms. It's an umbrella term that includes route planing or route surface debridement. And the reason we went for route surface instrumentation was to avoid having to get bogged down in the detail of whether you do route planing or whether you do debridement. Now, it's a particular area of interest in the UK because some of you may have been familiar with the work of Bernie Keezer, who sadly passed away a few years ago, back in 2009, actually, a long time ago. I'm getting old. But he did some very nice work where he demonstrated that if you, and it was all in vitro, if you take an periodontally infected tooth and you literally blast it with water, the endotoxin is completely removed just by rinsing the root surface with water. If you use air and water, then it's even more effective. And so having shown that, it kind of followed on. You might be familiar with the work that Sturry Nyman did, where Sturry Nyman did a study where they did surgery, open flap surgery, and polished the root surfaces in half the mouth, and in the other half of the mouth removed all the calculus. So did full root planing. And there was no difference in the result of healing from just leaving the calculus behind and polishing to get rid of the endotoxin.
Yeah.
And what Bernie Keezer's work did was it kind of provided the rationale and the biological explanation for why you can be less aggressive with your instrumentation.
Yeah.
So we did a study many years ago. I presented it at the IADR, but never published the paper. I'll tell you why in a minute. But what we did with the study was we repeated what Sturry Nyman did. We used an ultrasonic scaler. We split the mouth into two halves. Half the mouth was treated, and we took 45 minutes for each quadrant. Half the mouth was treated with traditional scaling and root planing with the ultrasonic scaler. And then the other half of the mouth was treated with no contact. So the machine we had was a Dentsply machine. They introduced for us an alarm and a flashing light and a noise. So when you touched the root surface and made contact, the alarms went off. So okay. the entire half of the mouth was treated using the ultrasonic scaler purely for irrigation, for the cavitation, for the microstreaming, but we left the calculus behind. And there was no difference in healing after 9 months between the two sides. Mm-hmm. And I remember Jan Linde saying to me when I presented it at IADR, you must write the paper for, for Journal of Clinical Perio. And Roy Page at the time said, you must write the paper for Journal of Perio. And we never did. We never did. Only time I was ever invited to publish some work by the editors. Never happened.
And why was that? Why was that you never wrote it?
So we never wrote it because, of course, if a specialist like you or me or many of the people on this call, if they are doing the leaving the calculus behind and they're doing the debridement, they have the knowledge and also the experience to review the patient very carefully. Yeah. And we also spent 45 minutes washing the endotoxin out in each quadrant as well. It was the same time. Yeah. Whereas in general practice, in the UK, the general practice in the UK, they would have said, we don't need to remove calculus. And they just would have done a bad job. and claimed the fee for doing a bad job, and the patient would suffer. And so it was a real ethical dilemma. And so what I say to people now is, well, you know what? You can leave the calculus behind if you can get rid of the endotoxin and it'll heal. But boy, the patient has to have good plaque control. You have to know what you're doing, and you have to monitor that patient very, very carefully. And really, I think I would only trust specialists to do that, really. And so that's why the paper was never published. So coming back to your question, Joe, so root planing is defined as removal of plaque, calculus, and infected and necrotic cementum. And the end point of treatment is a smooth, hard root surface. So when you do a session of root planing, you can go around and check at the end, and you know your treatment's been good because the root surface is smooth. But cementum is not smooth. Cementum is rough. So it means with root planing, you're removing most of the cementum. And any natural regeneration and bone regeneration that does take place, even without tissue regeneration, you'll get bone regeneration from non-surgical treatment. You're limiting the chance for that to happen because of the aggressive nature of the root planing. And what Bernie Keezer's work showed, and what our study showed, was actually if you just wash out the endotoxin, get rid of the calculus, sure, but actually don't strip all the cementum off the root surface, then actually you give a chance for healing and for more bone regeneration. So debridement is defined in the same way as root planing, but the endpoint is not a smooth root surface. The endpoint is determined 3 months later when you repeat your detailed probing measurements and you know if they've healed or not. So it's a kind of an uncomfortable feeling. You know, you're doing the debridement, you know you've got a rough root surface, you think you've removed the calculus, but you've got a rough root surface because you're leaving some cementum behind. You've just washed the endotoxin from the surface. But for you and me, we know when we re-examine the patient 3 months later, we know what we're looking for. And if the pockets have shrunk and there's no bleeding, okay, it's fine. But for a general dentist who doesn't have that sort of experience or that knowledge of the literature, it's dangerous.
You know why I think it's important, one of these questions, is actually to ask you if debridement, if the difference is mainly on, not on how deep you go with the curette or the hand instrument, if the difference is related to how much cementum you leave.
Correct.
So would there be a difference between, for example, if you were working on a shallow pocket? So would there be a difference between saying that I'm doing debridement or I'm doing scaling and root planing? For example, I mean here shallow pockets up to 3 millimeters as probing depth. So we know from the 90s that, and from reviews from Cobb, for example, that shallow sites actually, if you go subgingival, then you can lose attachment. So you have attachment loss. So that would be exactly the same for debridement or for scaling and root planing. Is that right?
No, so that's a really good question as well. So for me, it's all about the trauma you cause. So you're absolutely right. If you have a shallow site and it's healthy and you do aggressive root planing, you will induce attachment loss as a result of that. The pocket will probably shrink and get better, but you've induced some attachment loss. Whereas debridement is much gentler. With debridement, you would feel, if you can feel the calculus present, if it's there, you would remove it gently, and it's gone. But for a periodontitis patient with a shallow pocket, if I can't feel any deposits to remove, then I would just run a prophylaxis cup round subgingivally and just get rid of the biofilm. Just very gently remove the biofilm or most of the biofilm, so that you keep an aerobic environment and you keep a health promoting biofilm. For me, that's all you need to do with that shallow pocket. The difficulty you see, Joe, and I say this to my students, is if you have, say, a 5 millimeter pocket and it's not bleeding, then we know it can be stable. And so if you say review it in 3 months' time and it's still 5 millimeters and it's still not bleeding, then in the UK, we adopt the Scandinavian model. We would say, oh, well, you don't need to instrument it, you know, don't induce attachment loss, just maybe do some gentle biofilm removal and just leave it. But how many specialists, and I include myself in this, when you do a full mouth probing pocket depth chart, how many specialists actually also measure recession and attachment level? I don't. And so that 5 millimeter site may remain stable at 5 millimeters for many years, but actually you may have recession taking place. Yeah. So you may still be losing attachment. So we still in the UK like this philosophy of conservative approach, and like you've just explained, be gentle with your treatment and don't do root planing in a shallow pocket or a 3 millimeter site. But if it's a periodontitis patient and you've had attachment loss, then if you're going to do that, just keep an eye on the recession to make sure that you don't have attachment progression taking place. Okay, great. So I can see Magda is here. She is already excited about Colombia, that we're going to be in September, hopefully. Yeah, me too. I know. I've seen you there in the folder. And also we have some people asking questions about when am I going to ask you the questions. So you can just write your questions, everyone, in the chat. So at the end of the live, 10 minutes before the end, I will go through the questions with Dr. Chapple. Okay, so feel free just to write your questions whenever you feel you should. So that's great, Dr. Chapple. I really think that this is an important point, because this is something that we do on a daily basis, Yeah. So, and we already know that when to call someone, at an individual level, when, say, someone is a periodontitis patient, but identifying exactly where I should treat, or exactly where we should go for interventions. This is also something very important. I remember some papers, actually from Brazil as well, showing how supragingival supragingival control of biofilm can actually alter the microbiota in the subgingival part of the pocket. So this is actually very interesting as well. So maybe 1, 2, 3 millimeters, you don't really have to go with the curette, with the hand instrument. You can go with other ways. Just to be as careful as you can. Yeah. Great. Yeah, agreed. And I think also, Joe, it depends upon the risk status of the patient. If the patient is a very high risk patient, then there's a balance, isn't there? You might decide, well, do you know what? This is a young patient with grade C disease, and I'm going to do this carefully and thoroughly. And if I lose a tiny bit of attachment, but I'm deactivating the disease and stabilizing the patient, then you might make that clinical decision. And there's nothing wrong with that. There's no perfect solution. So sometimes for me, a little bit of traumatically induced attachment loss may actually be a price worth paying, just to make sure you stabilize and stop the disease progressing. That's perfect. Because, you treat the whole mouth, don't you? So you're treating, you mentioned the Cobb paper. Okay, really important paper, but it talks really about average reductions in pocket depth. And so, if the average reduction in pocket depth for somebody with severe disease is 2 millimeters, that means some sites that are shallow, they won't reduce at all. But the deep sites that are 9 millimeters might reduce to 5. And the average comes out at, 2.5 millimeters, something like that. So you're probably causing a little bit of trauma to the healthy sites, but the benefit is you're getting rid of the biofilm and reducing the biofilm, but you're getting a much bigger reduction in the deeper sites. Okay, yeah, great. So one of the sentences that you used is actually very interesting, because even though we try to provide a guideline, for experts, you can't just say always do this or always do that. This is really tough, right? So of course you should go on an individual case and see how your patient behaves, and this is completely different from one point to the other. But you mentioned something very nice as well, that is related to what to expect after scaling and root planing, or after debridement, after subgingival instrumentation, as people call it in the EFP consensus. So this is actually something that we should stop and think about,
because this is not only the paper of Cobb in the 90s, but it's also the work, I think it's Suvan,
Yeah,
who was the
Jeannie
first
Suvan.
author.
Yeah,
Yeah.
yeah.
And actually they show basically the same thing as Cobb showed in the 90s, that when you have a moderate pocket, that would be 4, 5, or 6 millimeters, you tend to have like 1 millimeter reduction in pocket depth. And about 50% of that as reduction in attachment loss. And when you have a greater pocket, so when it's a deep pocket, 7 millimeters or more, you have, as you said before, it would be like a mean, but it would be on average like 2 millimeters for depth reduction. This means that our subgingival instrumentation is extremely limited, right? So we should know what we are expecting right before doing the surgery or the subgingival instrumentation and so on. So no one should expect an 8 millimeters pocket to be 3 millimeters pocket after one single round of subgingival instrumentation. And some people may be very strict to the guideline when they see, for example, that, so we suggest that the 6 millimeters pockets should be treated with access flap. So, maybe it was an 8 millimeters with bleeding and probing, and now it's 6 millimeters without bleeding and probing. I mean, wasn't my subgingival instrumentation really working? I mean, maybe it should be time for another round of instrumentation instead of going straight to access flap. So how do you see these endpoints that we have, not only for clinical trials, and I know that Magda has one for clinical trials, but also the Needleman one of 4 millimeters and no bleeding on probing, as it's suggested for this consensus.
Okay, yeah, really, really important points, very important practical points. So we actually, in the classification workshop, the most contentious thing we discussed was the 4 millimeter site being a closed pocket. And we eventually had to have a vote on it. And the vote was just in favor of the 4 millimeter closed site. That was some work done by, well, lots of people, but in particular Jan Venstrom's work with Cristiano Tomasi. And so that certainly in the UK, we adopt the 4 millimeter site as a closed pocket. So if it's 4 millimeters or below and it's not bleeding, then you assume it's stable. And I think that is a really important benchmark. To come back to your point on what do you do if you get a reduction from 8 to 6 millimeters, do you go straight to surgery? I would never go straight to surgery in that situation because the patient's improved and maybe another round of debridement will give rise to a further improvement. And it often does. Because I always say, when you start treatment with a patient, what do you know about that patient's mouth? Well, you know the patient's a smoker or not. You know there's a family history. You know the patient-specific risk factors. You do a patient-specific risk assessment. Then when you examine the patient, you do a mouth-specific risk assessment, maybe tooth-specific. You'll know if there's some crowding, if there's a particular tooth that has a bad position that's going to be harder to maintain. But it's not until you've treated the patient and you do that post-therapy detailed chart that you start to get the site-specific knowledge of where the risk factors are. Because when you look at that post-operative chart, that most sites will hopefully have responded. But the ones that haven't, you will examine them in more detail. Maybe you'll find a root groove on a lateral incisor, or maybe you'll find some anatomical factor that is the reason that particular site has only reduced from 8 to 6. And then you'll do something additional, maybe just show the patient what to do in that particular site. Now, it's really interesting. We because of COVID, we had a problem like you guys where patients were not seen for many, many months. Yeah. And I remember last month, a patient who was seen in March of 2020, who had lots of sort of 6, 7 millimeter probing depths in their mouth. And it was a student case. And the undergraduate student had spent 40 minutes giving behavior change advice, oral hygiene advice to the patient, etc., etc. The patient came back
1 year later, and another student, and this was after COVID, repeated the full mouth detailed probing depth chart. There were no sites above 4 millimeters, and the patient had had no instrumentation whatsoever.
Wow.
And so, I mean, one of the things that people don't appreciate, if you look at the literature and you delve into the details of each individual randomized trial, you will find that the biggest percentage of pocket depth reduction happens just with the plaque control and what the patient does at home. Then what the scaling does is it gives you a further improvement. And then what the root surface debridement does, it gives you a further improvement. And so the amount of active sites comes down, you know, gradually with each step of treatment. And then when you get to maintenance, you will still have some sites that maybe are 5 or 6 millimeters, but not bleeding. And the paper you referred to by Magda and colleagues in the Journal of the International Academy, it was kind of written for clinical trials, but I actually think it's relevant to clinical care as well.
Yeah.
Because how often do you get a patient with 0 sites, you know, that are bleeding and that are above 4 millimeters? It's incredibly rare. And you know what? I think it's okay to have a small number of sites where you have maybe 5 millimeters or maybe 1 or 2 6 millimeter sites that aren't bleeding. If you monitor them carefully and you watch them carefully for the reasons we discussed earlier on. So, so in the British development of the European guidelines, we have put a statement in there to make it very clear. We do not expect you to go straight to surgery for 6 millimeter sites. But you know, if you're a specialist and you've treated the patient in your specialist practice and you've done it to the best of your ability, and the patient is motivated and you have a 6 millimeter residual site, then you might decide as a specialist, well, okay, I've tried this non-surgically, it's not worked, I'm going to go to surgery at that point. And for me, Joe, the issue you're highlighting here is one of efficacy versus effectiveness.
That's the point. Yeah, exactly.
Yeah? So the guidelines are based on efficacy studies done in controlled environments, in ideal conditions, because that's what you do with the clinical trial, and the systematic reviews are kind of, you know, based on those studies. But in the real world, where we're looking at effectiveness, we know that there is plenty of scope and room for another round of non-surgical treatment before you do surgery.
That's absolutely true. Yeah.
So that's the difference. Whereas in Southern Europe, you know, in Spain and Italy, they're much more surgically orientated. So they would tend, there's a difference between Northern and Southern Europe in our approach, our philosophical approach. And the literature supports both approaches, but we tend to follow, in the UK, certainly the Scandinavian approach and the Northern European approach, which is the one you flagged and you highlighted. We tend to go more for repeat the non-surgical treatment and only go for the surgery when you really think you have to.
Okay, great. I think we'll have another opportunity to discuss surgery, but I don't want to skip steps. I know it is my fault, of course, it's not yours, but I moved on to surgery before ending or finishing all we had to discuss about step 2. So going back to step 2 then, I'd like to know about the abilities that we have to overcome difficulties of subgingival instrumentation. So, of course, there is adjunctive therapies. They can be used either at the first time the patient shows up, or they can be used after a reevaluation, for example. And then, as you told me before, you can expect, or you know what to expect from that patient and from that specific site, and then you already know how the patient behaves to your treatment. So some of these adjunctive treatments, one of them actually is chlorhexidine.
Yeah.
So the antiseptics with chlorhexidine as a mouthwash. My question to you would be, in EFP, they say about short terms or short periods of, what would be a short period of using chlorhexidine? Because in the literature, sometimes you see 7 to 14 days, sometimes 21 days, but you also see works like using longer periods, like 60 days to 90 days. So what would be the cutoff for a short period in
For
your?
me, it's interesting. I mean, I use chlorhexidine as a mouth rinse only preoperatively as a way of reducing the bacterial contamination in the aerosol. I would not use it as a mouth rinse for as an adjunct for non-surgical treatment. I use it after I've done periodontal surgery to help support plaque control, and I would only use it for 7 days because the staining, it depends on the concentration. You see, in the UK, the chlorhexidine is provided in 0.2%, and it causes quite a bit of staining, which is rough and plaque accumulates, etc. In America, for example, I don't know about Brazil, they use 0.12%, which doesn't cause so much staining, but I don't think is as good in terms of its antimicrobial effects. So for me, 60 days is way too long. I would only use 60 days in a patient who maybe has a handicap or a learning difficulty, or maybe in a patient who is having treatment for cancer. Maybe they have multiple myeloma and they're immunodeficient as a result. So in that situation, fine, use it to support any way you can to get the inflammation down and change the composition of the biofilm. But for a patient who doesn't have that kind of issue, for me, I don't really see much benefit in the mouth rinse, to be honest, being used as an adjunct.
I think that it actually could also confuse your outcomes because, of course, we all know that this is a partnership between the individual, the patient, and the dentist. So if you insert, for example, this chemical, then you don't know what's the mechanical part that the patient is cooperating with you on the long term. So,
well, I think that's a really, really important point. Absolutely right. But also, it's not just the patient's cooperation. You know, it's the patient's threshold. Every patient has a different threshold for the amount of plaque in their mouths that will trigger disease. Some patients can have 100% plaque, and we know from the Harold Lowe's, Sri Lankan tea worker study, they will never develop periodontitis, maybe 10, 15% of people, because they're resistant to it. But the really high risk people, a small amount of plaque accumulation can cause a lot of damage. And so by treating the patient without the chlorhexidine and doing the behavior change and seeing their biological response as well as their behavioral response to that treatment, that's really important for you as a clinician and me as a clinician, knowing, is this enough for the patient, 20% plaque, or do we need to get them down to 10% plaque score? Everybody's slightly different. And you're right, if you include the chemical mouthwash at that stage, you don't know the answer to that question.
Yeah, perfect. I know Magda was here, so I think there is one question that you know what to expect right now, but we're still talking about adjunctive therapies. And one of the questions is that, and I agree with Magda in an aspect that maybe from all the consensus, what we have is that all the decisions were basically made upon the paper. I mean, very specifically on the paper. So the results of the paper comes very close to the conclusion of the basis paper that they had before, the systematic review.
Yeah.
But when it comes to antibiotics, especially for the systemic antibiotics, then we have a kind of a difference, because you have like low heterogeneity among the studies, and you have a high confidence on the results. We have clinically benefits with the adjunctive antibiotics, but when it comes to the consensus, it says that it's not recommended. And then you have some specific cases. Can you work a little bit more on how it worked, on how it was on the consensus? How was the voting and so on?
Yeah, I can. I mean, I never disagree with Magda, but the one area that we have a slight difference of opinion on is the use of systemic antibiotics. Now, Magda's work and also Andrea Mombelli and others has shown, I think, very nicely that if you use adjunctive systemic antibiotics, you get a better outcome. On average, you get a better outcome. And most of the early studies were short-term, 3 months, maximum 6 months follow-up. But obviously the more recent studies show a longer-term follow-up. The question is, what is the effect size of using the adjunctive antibiotics? And what would that effect size be in an effectiveness study, not an efficacy study, where you did more than 1 round of root surface debridement, maybe 2, maybe 3 rounds, and then compared the outcome to the use of the adjunctive systemic antibiotics. So, and also, you know, periodontitis it's polymicrobial. So which bacteria are you targeting with your antibiotics? Well, we don't really know. You're kind of nuking the bugs and clearing them all out. And that will give you, no doubt about it, a better impact, a better effect, if you like. But how long-term is it? How sustainable is it? Is the patient still motivated because they got a really quick result? Who knows? So the debate we had at the workshop was really about cost benefit. What is the benefit of using adjunctive systemic antibiotics in patients with periodontitis that is, if you like, grade A, maybe grade B periodontitis, not what we used to call aggressive periodontitis, the grade C disease where the patient has a relatively clean mouth.
Yeah.
And what is the cost in terms of the cost of the antibiotics to the patient, but also the environmental cost. And the environmental cost was the main issue. And so you're absolutely right. The outcome of that was, well, there were 2 outcomes actually. For regular periodontitis that we used to call chronic periodontitis, there was a very clear statement that the workshop group felt that the environmental impact of the antibiotics did not justify their recommendation at all. And so there was there was the recommendation against their use. Mm-hmm. But then for patients with grade C, I think there's actually, I'd need to check, I think there's an error in the paper. I think it says grade 3, but it means grade C. So for somebody who has a very high risk, what we used to call aggressive periodontitis, we know that in that situation, from all the work done at the Forsyth Centre by Sig Sokransky and Anne Haffergy and colleagues back in the 80s, we know that actually in that situation, you really do need to use systemic antibiotics to get rid of the AA. If you don't use systemic antibiotics, even if you do surgery, you will not eliminate AA from the mouth, and it will come back. And in those cases, you have a problem. The disease won't stabilize. Mm-hmm. And so there is that caveat for people with grade C periodontitis where you feel you need some additional support, then systemic antibiotics in that situation is something that you might wish to consider doing. And certainly I would always use systemic antibiotics in that situation. So I kind of, I use them for people with aggressive periodontitis or grade C, where they've got clean mouths and no obvious local risk factors. But I've never used systemic antibiotics for patients with grade A or B periodontitis, and I've never had a problem getting results. I get results. So
I agree with you.
Why use them?
Exactly the same. Mm-hmm. Actually, so 2 points there. I think that the effectiveness problem is not a problem only for systemic antibiotics. It's a problem for dentistry as well.
I agree.
As an overall, So this also applies, for example, to the next topic that we must go like soon. That is, for example, access flap and other kinds of surgeries, because sometimes we have like one site or one exact definition that is covered by a clinical trial, but this is not actually what we do on a daily basis. But before moving on to surgery, just let me ask you, is there a specific why reevaluation was not considered in this consensus? I mean, after we go for a round of subgingival instrumentation, we have to reassess or reevaluate our patient to see where he goes from now. So they can go to step 2 again, they can go to step 3, or step 3 going back to another round of step 2, or they can go straight to step 4, for example. So is there a specific reason why you haven't, why the consensus haven't reached anything about time for reevaluation? And is it important actually before considering the next steps?
It is important. The reason that we didn't was because the entire workshop was really planned around interventions, different types of interventions, whether they be behavioral interventions or whether they be physical interventions.
Makes sense.
Yeah, and of course, you know, the recall period, the review period is not an intervention as such, it's a reevaluation. But it is critically important. And so normally we would reevaluate at 3 months. And the reason we do that is that we know that if you debride a pocket in a motivated patient, the healing has really 3 components to it. The first component is the reattachment of the long junctional epithelium, which takes maybe 7 days, 10 days. The second component is the resolution of the inflammation, because as the inflammation resolves, you know, the pocket will start to shrink a little bit and tighten up a little bit. That takes roughly 2 weeks, maybe 3 weeks. What takes the longest is the collagen recross-linking and tightening, as you know, and the tightening of the gingival cuff. And that takes up to 3 months. And so that's why we kind of say 3 months is probably enough. There is some evidence in the literature to suggest that if you didn't review at 3 months and the healing process was taking place, you would get even more pocket depth reduction by 6 months. So leave it for 6 months. The problem is you don't know if that healing process is happening long term. And also the 3-month checkpoint with the patient gives you the opportunity to talk to them, to say, how's it going, you know, and to check any areas they're missing and to remotivate them, check on their risk factors. So that sort of touch point in time at 3 months is very valuable just for remotivating the patient, reinforcing the message. So I always go for 3 months, always. But I have some patients who, you know, when they're stable in supportive care, I don't see them for 12 months because their plaque control is brilliant. And, you know, most of my medical colleagues who I treat for periodontal disease, they're so motivated that I see them once a year and I still have closed pockets with no bleeding and very little, if any, plaque. So you have to do it on a case-by-case basis, really.
Yeah, that's one of my main concerns here as teaching undergraduate students is something that we see very often is that a patient comes and then after we have the last session of scaling and root planning, do your patients go back to a hygienist or anything, or they just go home and stay home for 3 months and then they go back to you? How does it work for you?
So no, we send them home for 3 months and they, you know, we're a referral center, but I specifically say, don't let your general dental practice do any subgingival instrumentation. You're not to see them. I want a 3-month period of uninterrupted healing because like we discussed earlier, if you've got healing taking place and you go in and scale subgingivally, you might disrupt the healing and cause problems.
Yeah. So I think that the main point here is that what I see actually very often is that the patient goes home and after 3 months, or maybe sometimes after 2 months, after 60 days, that is generally what we use here, the patient doesn't come back with the same quality of hygiene as they had while they were being supervised. And this is a little bit like the Hawthorne effect, you know? Whenever you're being evaluated and whenever you're being like under treatment, then you tend to use better plaque control. And then, but of course, that depends on the culture, on the backgrounds of the patient. So it can be different between cultures and between the type of economic status, for example, that your patient has and so forth. So yeah, but again, I agree that it's case by case.
Yeah.
So Hussein is saying that Suvan's paper suggested a 3-month period, but I didn't mean about the specific papers. My question was regarding the consensus, why the consensus didn't have a position about this. So let's go to the last question.
Sorry, Joe, what I will say is we're about to run the S3 guidelines for stage 4. And the S3 guidelines for stage 4 will also look at patient outcomes and at supportive therapy and the effectiveness of supportive therapy. So some of this information should come out as part of the next set of guidelines for stage 4.
Great. So my last question to you before moving on to the questions of the audience would be related to access flap. And I think that sometimes it goes straight to the same topic that we were discussing before related to antibiotics, because sometimes we have one outcome from clinical trials, and you base your recommendation on that outcome of the clinical trial, or on many outcomes of clinical trials. But sometimes you just don't consider other things that would be important for the patient on a daily basis. Again, it's efficacy versus effectiveness. And maybe my question to you would be, the paper about open flap, they don't show differences after 1 year in clinical attachment level. I think there is no difference between the two groups, opening or not opening, even in deep pockets. What they see is some difference and small differences regarding pocket depth, and this is almost none after 12 months, if I'm not mistaken. And so basically, after 12 months, you don't have much of a difference. But what you see as a difference is that shallow sites, and sometimes you do have this, you insert or you include in your flap, you include healthy sites or moderate sites that are going to lose attachment if you're going to conduct. So your view on access flap, and here I'm saying just in general, I'm not saying about specific defects that sometimes we know that they are more beneficial, but like in general, would you say that it really is recommended? It really is literal, as we see in the consensus, that they suggest that 6 millimeters or more should be treated with periodontal surgery. So what's your view on periodontal surgery, this access flap?
Yeah, so I mean, we all love doing periodontal surgery, let's face it. I love doing periodontal surgery, we all do. And so there's always a temptation just to do it surgically, because it's much easier to do open flap debridement and get a good outcome in terms of the quality of the debridement. It's much easier to do it with a flap than without a flap, because you can see what you're doing. But my view is that, so when I started in perio, I used to raise whole quadrant flaps and do the surgery. And as time's gone on, I realized, crazy, yeah. As time's gone on, I realized, what, non-surgical treatment works in most sites, in most patients. So my view would be, if I've tried non-surgically and I have 1 or 2 sites that haven't responded, and I've re-instrumented them and they still haven't responded, I will then decide, okay, I'm either going to use a local antiseptic or antimicrobial delivery system, or I'm going to raise a very small localized flap in that area so that I can visualize the root surface and just see what's going on. Why is it not responding? Because if the plaque control is bad in that site because of the position, say it's a buccally positioned tooth, patient's just not cleaning it, then you show them how to clean it and you don't do the surgery. But actually, if there's no reason why, then I do like to raise a flap in that situation to check there's not a groove in the root or a crack or some kind of concavity or something like that, that gives me more knowledge and understanding of why that site hasn't responded. And I can then share that with the patient, and we work out between us how they can sort of maintain that particular area. Because when you go down that journey with the patient, the most motivated patients will say, oh, what's happening on the distal of my upper right 6? Because there was a 6 millimeter pocket last time you probed. They know, they remember. They have like a map in their brain of their mouth. And you say, well, I don't know what's going on with the 6. It's still bleeding and it's still 6 millimeters. Well, what are you going to do about it? Well, let's have a look. We'll numb it up and we'll raise a flap and we'll take a look. So I've become more conservative as I've got older, and I still do the surgery, but nowhere near as much as I used to. And it's more localized to those localized sites. And the reason the term suggest is used in the guidelines, it's not a recommendation, it's a suggestion. It means the quality of the evidence and the justification for the surgery is not really that strong, but on balance, it's probably worth thinking about doing. So it's a suggestion, not a recommendation.
Okay, great. So I think we are 5 minutes from the end. There was one more question that I'd like to ask you, but I'm not going to ask you because someone asked the question that I was going to ask you. So I'm just going to read you the questions that we have here. And so the first one would be Perio Naveia, Dr. Chapple. How deep were the pockets in that study in which the calculus were left behind? I think it's your study that you mentioned in the beginning.
Yeah.
So can you remember how deep the pockets were?
Yeah, they were the full range from 5 up to 8-9 millimeters. It was a good going case. Yeah, good going case.
Great. So another
Before
question.
I forget, Joe, while people are on, what I will do, we did a table of terminology for your earlier question about root surface instrumentation for the BSP. I will send you a copy of it because it explains the terms and which ones are common and fit under PMPR. I'll send it to you because it's quite a useful synthesis of the terms over many years.
Okay, and I can share it with the Brazilian Society and they can even...
Yeah, do.
Yeah, sure. So the question
the
that
BSP will let you you can reuse it if you wish. I'm sure the British Society will have no problem. It's just, why not? Okay. Share it.
Great, thank you. The question that I was going to ask you is, do you feel that that approach is appropriate for non-specialists? So the point is, if someone here is an undergraduate student and is not intended or is not going to specialize in periodontics, and they face someone who is a periodontitis case, so someone that has periodontitis and should be treated. So what should they do? Because they won't be doing the periodontal surgery. I mean, I don't know, but probably. No. What should they do, at least in the UK? And then we can discuss here as well.
Well, it's really interesting because in the UK, we classify cases according to complexity. So we have 3 levels of complexity. And in a general dental practice, where you don't have any specialist training, you should only be managing complexity level 1 cases. And those would be cases that were stage 2 or stage 1. If you have stage 3 cases, then they should be referred to a practitioner who has what we call enhanced skills. So they are not a full specialist, but they have done some additional training like a master's and they have a lot of clinical experience. And they may have a contract to see what we call level 2 cases. And level 2 means patients with moderate periodontitis, CPI-10 code 3s, maybe shallow code 4s. And then the complexity level 3 cases, they are seen by specialists and consultants. So we actually have a staging in the National Health Service system.
That's a great idea, actually.
Yeah.
That's a great idea, yeah.
I can send you again, I'll email you the flow chart that shows the complexity levels. So actually, when you think about it, there's no way a general dental practitioner in the UK would ever be prescribing antibiotics systemically anyhow, because if it's a grade C case, they're seen by a level 2 or a level 3 specialist anyhow. And when it is a patient that requires surgery, they would be referred by that general dentist again to the level 2 or the level 3 specialist for management surgically. So it's a kind of a nice system. It works very, very well. And the patient moves from the general dentist into the level 2 and into the level 3 specialist if they need to.
That's awesome. That's very nice. And this is something that we should also apply here in Brazil. I mean, of course, there is legislation. There is a lot of things related to law and everything. But this is something that is pretty much needed. You know, I think that many times, and this is not just in perio, this is a reality for many other specialties. And this kind of difference in the levels of knowledge should also be applied. So, Dr. Chapple, I don't want to take any more of your time. I'm sorry, we still had some questions here, but our live...
I'm happy to continue for another 5 minutes if you wish. It's up to you. I don't mind.
Actually, I'm not sure if a live generally goes down after 1 hour.
Okay.
So my only concern is that we go down and we don't have time to say goodbye.
Okay.
So actually, what I'd like to say is that I'm pretty sure that the Brazilian Society of Perio, all Brazilian periodontists, and myself, it was really a pleasure to have you here with us. I learned a lot. I'm sure my colleagues learned a lot as well. I can see many comments here in Portuguese and in English saying how great you were, big fans of yours. And it was very, very nice to have you here. And it was a wonderful talk. So thank you very much. And I'd like to hear your some words from you as well.
It's a real pleasure, and it's an honor for me, and it's nice, actually. I can see Vir and Vitlana. You have some British people on this call as well, so you guys in Brazil have done a really good job here in setting this up. No, it's an absolute pleasure. I enjoy these discussions. They're very important because they give the context to what we read in the published literature, which sometimes, if you read it without the context, is it's not very helpful. So it was a great idea, and I thoroughly enjoyed it. And I'll send you some stuff.
Okay. Yeah, great. So, and I'm going to send it to the Brazilian Society, and then everyone can access. So thank you very much once again. It was a pleasure once again. And take care in the UK. And we are also taking care here in Brazil.
Yeah, and I hope to see you soon in Birmingham.
Yeah, so do I.
Okay.
Bye.
Thank you.
See you.
Bye-bye.
Tchau, pessoal. Tchau, tchau.
Ciao.